Hello guys, I hope you're doing great. This is Dr. T speaking from Clinical Medicine with Dr. T. Guys, welcome to this episode, and if you're watching for the first time, I welcome you as well. So guys, remember late last week I introduced to you guys a new feature in the channel. This feature, I call it a patient I saw. So like I said, I'm gonna, whenever I see a patient that is worth discussing, a patient that I have seen and managed, I will come back and tell you guys about that patient. So we're trying to make it as practical as possible. I've got the information of this patient here in terms of the blood results and stuff, not the names obviously, just the age and what they came from. So this patient is a female, 51 years. She came to the hospital on Monday, but I was not the one who saw her on Monday. A different doctor saw her. So she came in complaining of jaundice. And this jaundice was noticed by someone else about a week ago. It wasn't there for a week, but it was noticed a week ago. Co-colored urine. I say this is textbook stuff. Co-colored urine. This one was the patient said it's been there for about just over a week. That's what she said. Loss of appetite plus weight for over a year. So it turned out that the main problem that has been bothering this patient is the loss of appetite and the loss of weight, which has been there for over a year. So the doctor who saw her examined her and didn't find the only thing that was there. So also itching of the skin. So the only thing that the doctor that saw her last on Monday was the jaundice. So he did confirm the jaundice, but couldn't find anything else on the abdomen. Couldn't find hepatomegaly, couldn't find a positive Murphy's sign, couldn't find epigastric or right upper quadrant tenderness, abdominal soft and non-tender, the vitals were normal. So based on this, the doctor made an assessment of query obstructive jaundice. By the way, this patient, I saw the doctor who saw this patient, the notes. It's one of the, I've been telling you about this guy, Dr. Sitlenya was a very good doctor, very good intern. Love to work with him so much. So obstructive jaundice. So he queried obstructive jaundice, and the patient was fine. So he just took bloods and told the patient to go home and come back today. So these are the bloods. He took a lot of bloods, but I'm just gonna tell you about the abnormal ones. So the vital signs of the patient today, the patient looked fine clinically, didn't look toxic at all. So the blood pressure was 134/76 with a pulse of 79 and a temperature of 37.8, and she surprisingly had an albumin of 25, and the INR was normal. Total bilirubin of 282, and the normal should be is between 5 and 21. That's high, guys. That's like sky high. And she also has a white cell count of 22,50, CRP of 69, had a GGT of 221. Remember, a CRP of about 20 is fine, but once it gets there, it's very high. And the white cell count, I mean, this is sky high as well. And then GGT, the normal there should be less than 40. And then the ALP, this varies from different labs, but this is high, guys, from lab to lab. So it's important to, when you do blood test, it's important to put the sex of the patient or the gender of the patient and the age, so that they can work out the reference range for you. So ALP was 289. The normal is 42 to 92 according to this lab that we're using. And the AST was 40, like this is normal, guys. No, the ALT. Remember, ALT, A liver T. This is the most specific transaminase for. Please, guys, if you have not watched approach to LFTs, go and watch that tutorial, approach to LFTs. So the ALT is the most specific, which was normal, and then the AST, and AST that is high does not bother as long as the ALT is normal. It's not bothersome as long as the ALT is normal. So, but the AST was 81, slightly high. And he also did a lipase, which was 20, which was also normal as well, because the upper limit there is 60. What else was normal? He also did an alpha fetoprotein, which was also normal. So why did he do an alpha fetoprotein? So an alpha fetoprotein normally in some cancers of the hepatocytes, it normally goes up. So because he just had a jaundice, he was not sure where to shoot, so it was good for him to take the alpha feto as well. Why did he take lipase? Remember, when you've got gallstone pancreatitis, you are gonna have a high lipase. And also, yeah, if you've got gallstone pancreatitis, you are gonna have a high lipase, and the patient will appear jaundiced, but they'll also have epigastric tenderness and all of that. So yeah, that's just one of the reasons. And then what else? He also did an ESR, which was 126. ESR just tells you about inflammation. It's an inflammatory marker. So guys, if you can now sit and analyze these results, we can see that our patient has got leukocytosis. Our patient has got a high ESR, and these they point to infection. And this temperature is high. Remember, a high temperature is regarded as 38, but it's only about 0.3 before it gets to 38, and we don't know when can that happen. So I'll take this serious, especially in the presence of this. So now this patient now had these three things, and his suspicion of obstructive jaundice is confirmed by these blood results, because these are high, guys. Your cholestatic enzymes are high. Your GGT and your ALP, they are very high. As much as, and I said, the ALT at 40 is normal. AST is also slightly high, but these are much more higher than these ones. So we do confirm an obstruction here, a biliary obstruction, but we still don't know what's the cause of the obstruction. But that doesn't matter. At this point, it doesn't matter. What matters at this point is that we've got obstructive jaundice with what? Go, guys, and look at acute cholangitis. This patient, as much as clinically she looked fine with normal BP and a normal pulse. But the fact that we have these two, 1, 2, and these being high, it was telling us that this patient is developing acute cholangitis. So this is the reason why when I was looking at these results, I had to stand up and look for a surgeon. So luckily they were around, so I went to discuss this patient with them. And you know, guys, one of the things that we really have to study, guys. We really have to read, we really have to study, because you know, when you try to refer a patient to a specialist, I mean, it's no secret that people who are working in specialized departments, they don't really think that there's anything good that can come out of us. It's just the way it is. It's just the way it is. It's just the way it is. And so I had now to go and argue my case with this guy. So I presented this patient, and initially he said to me, you know what, we can give this patient Augmentin and ask the patient to come back on Monday to SOPD. And then I was like, okay, doc, I do hear you and I do understand, but my problem with this patient is that we are having a developing acute cholangitis, and giving a patient Augmentin and you ask them to go home. I mean, well, first of all, patients and medication, sometimes some patients will come with so many stories that, yo, I couldn't get the medication last week, I forgot my whatever. Patients, they come with stories. So I wasn't gonna allow this patient to go home and take oral medication when already we can see that she's developing cholangitis. So there are so many stories that patients can come with. I took one tab and then I couldn't find my medication again. You know, we went to a funeral and I forgot my medication. You know, those kind of stories. But I was trying to avoid a situation whereby we have this patient come back on the weekend, on early next week, with a full-blown acute cholangitis in sepsis and all of that. So that's why I was like, hey, doc, you know, I'm really skeptical to write this Augmentin. But luckily, the doctor that I was discussing with eventually started to make sense to him that, you know, actually, once we've got a high white cell count now and a high CRP, we should take this patient serious. So what I was expecting from him is to say, okay, let's admit this patient, put on on IV antibiotics, and also book this patient for an abdominal ultrasound and see what's causing the obstruction. But then eventually he agreed, and then that's what we ended up doing. So so this patient is admitted now on IV antibiotics, and I think it's gonna have a scan sometime this week, an abdominal ultrasound sometime this week. So what I want, guys, you to take from this is that when you have an obstructive jaundice patient, the cause of the obstruction is not going to be the one that's going to kill the patient there and there. But acute cholangitis will kill the patient there and there. A patient who's got obstructive jaundice is fine. Inflammatory markers are normal. Blood pressure is normal. They don't look sick. That patient can can go home and come to the clinic, SOPD clinic, in the whatever time the patient is booked, whatever. So the patient can come in basically anytime, but it shouldn't be too long, because you don't know when the acute cholangitis will begin. And acute cholangitis is very lethal. Like I explained, that once you get to SIRS, like systemic inflammatory response syndrome, the body is going to try and respond to the infection, and then this is going to happen. And once you get this, you are likely to get to multi-organ dysfunction syndrome, and you get your liver now being abnormal you get abnormal LFTs. When I say LFTs, I'm talking about abnormal INR. You get now a heart that is not pumping well, cardiogenic shock. You get a liver now that is kidneys that are having high creatinine and high urea. So you get multi-organ dysfunction and you get to multi-organ failure. So now, so that's very important. So when you see a patient with obstructive jaundice, you need to make sure that they don't have acute cholangitis. That's very, guys, I cannot overemphasize this. And secondly, remember, anything that can cause obstruction in the biliary tree has got a potential to cause acute cholangitis, not only gallstones or cholelithiasis. Not only that, a tumor can obstruct there. A lymph node can cause extrinsic compression of the CBD. Anything, guys, that you can think of can cause obstruction in the common bile duct, and because of that, the patient runs a risk of having acute cholangitis. And acute cholangitis is an emergency. Obstructive jaundice is not an emergency, but if there's acute cholangitis, it becomes an emergency. That patient will need an urgent ultrasound and possibly an urgent ERCP. Some places they do lithotripsy, or some do transhepatic biliary drainage. So I think where I'm working, this is what they have, ERCP. So guys, that's that. And as GPs, it's very important to be it's very important to be on top of our patients, in the sense that, because if you want to argue your case to a specialist, they want to know that you really know what you're talking about. And now if you start not being sure, they won't take that patient. That patient is going to die on you. Even though you can say, I discussed the patient, but the fact that you didn't tell the specialist the things that make you to say, Doc, I really need you to take this patient right now, they are not gonna they're not gonna take the patient. So it's like saying, Doc, I've got an obstructive jaundice patient. Then they say, oh no, send that patient next week. And yet your patient has got obstructive jaundice that is complicated to acute cholangitis. So that's that, guys. That's really that. So I'm gonna do a follow-up. Luckily, I'm good friends with this doctor, so I have his number. I'm gonna do a follow-up and see what is the cause. But we think that this patient has got one of your biliary tree cancers because of that loss of appetite and loss of weight for about a year. We don't really think this patient has got gallstones, but we will see. We will see. So guys, that's it. A patient that I saw. Thank you and bye.